Hello everyone, and welcome to another edition of Cosmetic Corner. My name is Chris Surek, your moderator, and we are very fortunate today to have Dr. Frank Lista as our expert discussant. As many of you know, he is a thought leader in the field of breast cosmetic surgery, and he is one of 3 breast surgery section editors for ASJ. We are truly grateful that he has taken time to visit with us today. Dr. Lista, how are you?
Hey, great. Thanks, Chris. Thanks for having me.
So today we're here to discuss a very interesting article on looking at the use of Galaflex, Scaffold, and Ptotic Breast surgery. First off, we commend the authors on a great article. This is a collaboration of 6 plastic surgeons, primarily authored by Dr. Bill Adams. And overall, this was a very impressive study, well designed with several measurement parameters. The overarching premise was that the scaffold helps poor native soft tissue quality that may have otherwise resulted in early recurrence in ptotic breast surgery. They do address limitations in the study, and it is worth noting that this was an industry-sponsored study. The results assessments was done at fixed time intervals and used physical exam, 3D imaging, and patient and physician satisfaction scales. So Dr. Lista, let's dive right in and talk about some components of the article. You have a very busy practice, and you're an excellent educator in cosmetic breast surgery. As a matter of fact, I know that you recently did a teaching course at the ASAPS meeting in New York. So can you share with us just your initial thoughts and impression on the article, maybe what you found to be the take-home points?
Well, the holy grail of breast surgery in patients who have breast reduction or ptosis is to prevent the recurrence of the ptosis. And so what we're searching for is a material which is easy to use, absorbable, but that has a permanent effect. And so the paper shows good results with this procedure and this operation. I mean, there are some shortcomings and some caveats that we need to look at, but as a proof of concept, it's a good beginning.
Now, the authors address specific advantages of the Galaflex to other materials in their minds, claiming that it is absorbable but maintains strength well into the scar formation phase. Have you personally used Galaflex or any other meshes for breast support surgery in your practice?
Well, we've used micro mesh. We've never used Galaflex. It's not available in Canada yet.
Okay. Now, but just knowing that the composition of Galaflex and this concept of absorbing but maintaining strength during scar formation phase, does that appeal to you, or what are your thoughts on that?
Well, for sure. I think the thing that we're worried about is putting a permanent material close to the skin, under the breast. How's that going to react over time? What's going to happen 10 years from now? So the idea that you could put something in that is going to be absorbed after a year and yet creates a permanent scaffold which holds the breast up is really intriguing.
Now, 3D imaging was utilized in this study, and this is a hot topic right now. Many surgeons, Dr. Adams included, state that it's a real game changer in their practices. In your breast cosmetic practice, do you utilize 3D imaging or any type of other imaging software for your consults?
Well, we do have 3D imaging. I have to tell you quite truthfully, I've never found it as useful as Bill has. I think there are some things that it does very well, especially when you have a discussion with patient about size, and there's other things that it doesn't do so well. For example, a recent paper by Mitch Brown shows that it's not very good at defining the width of the breast, which, as you know, is a critical dimension in breast planning. And so it's not great at width. Which is a problem, especially if you're using it for breast implants. On the other hand, for measuring ptosis, because it's a lateral view, it's a perfect device.
Now, one thing that the authors did not address in this study, but is curious to me, is that obviously in aesthetic surgery practices and a cash-based system, it would appear that Galaflex would be an out-of-pocket cost. And so, you know, this is probably an important factor. Obviously, Vicryl also is an out-of-pocket cost, maybe not quite as expensive, but how do you envision if this became a part of someone's practice, you know, explaining the cost, and is the cost benefit worth it? That's really the question, right?
Well, okay, so there's 2 questions. First of all, if you are a surgeon who routinely uses this on a breast lift, a mastopexy, and your fee is going to be higher than the guy down the street who doesn't. So patients, that may make it a barrier to entry for patients to your practice because, you know, you're more expensive and they haven't talked to you yet to find out why. The second part of your question is really the important one. Although the authors show good results, the real question is, are the results better than not using Galaflex? Of course, the study doesn't show that. And so what we need to know is, does the use of Galaflex justify the cost, the increased risk, and any other potential complications which could arise? Indeed, the paper shows that there are some complications relating to the device itself. And so what we really need, and that's why I call this a proof of concept paper, it shows that you can use it, it shows that the complication rate is low, but really what we need to know is, does using Galaflex make a better result than not using Galaflex? And that's going to need a study with control patients.
Yeah, very good point. Very good point. Any additional thoughts you have on this concept of Galaflex in this procedure?
Well, yeah, so there's two things. In the paper, they didn't go into a lot of description about how they use it, but the picture showed Galaflex over an inferior pedicle. So the idea being, if you can hold the inferior pedicle up, then it's going to help. Well, the question is, what if you don't use an inferior pedicle? What if you use a superior pedicle or a lateral or a medial pedicle? Where do you put the Galaflex? Because when you do a mastopexy in those cases, or a breast reduction with a vertical technique, you don't have anything in the middle to put the Galaflex to. So how would you use it in those situations? I think that's number one. And number two, the big question is, can you use Galaflex against an implant? And I'm not aware of any studies yet that show that or show the benefit of it, either in breast augmentation or to prevent bottoming out, or in breast reconstruction. Really, what people are trying to do is replace ADM.
That's actually a very nice point. Good. Well, thank you for sharing that little tidbit. You know, another thing about the paper was this patient and physician satisfaction scales that were used in the study. And, you know, as we continue to transition into this evidence-based world where anecdotal reporting has really become less accepted, these satisfaction scales, validations, unvalidated scales, you know, do you utilize any type of patient satisfaction scales in your practice, or how do you envision this concept affecting our research as we move forward?
Well, we're starting to, and you know, one of the things that that is most compelling, if you want to look at an example, is the use of various types of implants. So, for a long time, lots of surgeons have been advocating shaped implants because they say the result is better. But there are many studies which look at patient satisfaction that show that the patients who have breast reconstruction, for example, are equally as satisfied with a round implant as with a shaped implant. And so if patients are equally satisfied, should we be using this device which is more expensive and has a higher complication rate? That's an example where patient satisfaction study is extremely useful in helping you decide what you're going to do for a patient.
That's an excellent point. Excellent point. Well, we're nearing the end of our time. So, Dr. Lista, do you have any parting words of wisdom that you want to share with our residents, fellows, or young plastic surgeons in regard to mastopexy in our practice? Always can be somewhat of a daunting operation.
So, a little more, I mean, perhaps a little more general word of warning, especially when you look at a paper like this, is that it's easy to get caught up in the excitement of something new, and everyone wants to be using the latest thing, and so, you know, you're gonna look at this paper and say, hey, maybe I should be using Galaflex, but remember, no one's shown that it's better. So it's expensive. It has added risks and complications. What we really need to know is it better than what we used to do? And before embarking or jumping on the bandwagon too soon, I think we need to see some results of it, answering that question.
Well, Dr. Lista, thank you very much. Again, we want to commend Dr. Adams and the authors. It was a well-structured paper. Certainly piques our interest on Galaflex, but obviously, as with all things, we need to do the best we can to get the best evidence possible. So we'll keep learning more about this material down the line, I imagine. And Dr. Lista, thank you again. It was truly a pleasure having you on.
And thanks for having me, Chris.
All right, everyone, we'll see you next month. Thank you.